Nick Majerison here. Welcome to Top Med Talk, and welcome to today's Top Med Talk, which is Part 1, ASA San Francisco, Pediatrics and Opioids. This is Part 1 of the conversation, and Part 2 will be following tomorrow. Make sure you listen to the end of the podcast so you can find out how you can own the entire back catalogue of Top Med Talk. More details on that after this.
Top Med Talk.
This is Top Med Talk, and we are at Anesthesiology 2018 here in the Connection Center at Smith's Medical booth 1519. Now, this is day 3. We're wrapping things up here. The exhibit hall closes at 1 o'clock today, so if you haven't been, please come over and check out the booth. Check us out, Top Med Talk. We'll be having multiple conversations throughout the rest of the day. I'm Desiree Chappell, host of Top Med Talk, and I have here my good friend, co-host today, Dr. Mike Grocott.
Desiree, it's great to be back.
Yeah.
really enjoying San Francisco.
Yeah, having a good time?
Yep.
Yeah, have you done anything fun lately?
I did see the sun briefly before it went down last night at one of the the Duke department parties.
Yeah.
That was great.
I would urge you to take a field trip to study wine in Napa or Sonoma.
Yeah, really good.
That sounds very good.
So I have Mike here on my right, but I have my very special guest chiming in about Napa, which I definitely want to talk to you later about that. My very special guest, Dr. Myron Yaster. He is an anesthesiologist. He's in the Department of Anesthesiology at the Children's Hospital of Colorado.
It was formerly known as the Denver Children's Hospital.
Oh, gotcha.
It's part of the University of Colorado. The hospital moved to Aurora, so it's now called the Children's Hospital of Colorado, and it's one of the largest in the United States. It's about almost 500 beds. Wow,
that's great. Well, thank you so much for joining us
Delighted.
This morning, Myra. So, kind of jumping right in, your main focus. Tell us a little bit about what you do there.
So I was trained in pediatrics, anesthesiology, critical care medicine, and pain management. So I have actually 5 boards.
Wow.
Right.
Wow.
We used to be called double boarded, but now I think I'm quintuply boarded. Over the past, say, 30-plus years, 35 years, I was formerly at Johns Hopkins in Baltimore. I was at the beginning of the wave of recognizing that children and infants experience pain, and that this pain could be safely and effectively treated with the drugs that we initially used in the operating room, but then out of the operating room. So things like opioids and non-opioid analgesics. And we started at one of the very first pain services, and at one time we had on a given year, treated 5,000+ patients a year. And on any given day, we would treat 30 to 50 patients in the hospital.
Wow, that's fantastic. So what does your program look like now?
In Denver?
Yeah.
It's actually sort of different. The Denver program... So at Hopkins, the program was completely run by anesthesiologists who were almost also pediatricians as well. In Denver, it's more in much more multimodal, a lot more regional anesthesia, a lot less opioid based. So it's different. It's a different mindset actually.
Yeah. Well, I want to get to the opioids here in just a moment. But the focus here at Top Med Talk here at Anesthesiology 2018 has been around enhanced recovery. And we've been talking about different service lines, obstetrics. We're going to talk later today about cardiac. And I find it very interesting. I get this question a lot about pathways for the pediatric patient. So can you speak to that? Are
Sure.
you guys utilizing enhanced recovery at your facility?
So one of the leaders in ERAS in pediatrics is Megan Brockel, who was one of my colleagues at the Children's Hospital in Colorado. And I think the way to think about this is to take a step back. If you look at the 30,000-foot view, is that if there's any constant in medicine, it's change. So whatever you did in the past, it's very unlikely that that's what you're going to be doing 10 years from now. And we went from children theoretically not having pain to recognizing that they do have pain. And then we went from, if they have pain, then we have to go to great lengths to treat it, and we went to the whole thing of pain as the 5th vital sign. And the focus of pain management became opioids, not knowing that that was going to create its own set of problems, that there is no free lunch, as we always like to say in medicine. And in Colorado, they have been really at the forefront, amongst other places, of going to multimodal therapy where regional anesthesia, local anesthetics, and non-opioid analgesics are going to play a big role. And so that's changed a lot. So we use much less opioids than we used to in the past. We're using other modalities. And one of the more interesting things is that if you take the long view, we're probably also going to be at the forefront of using things that are currently illegal in much of the United States, which is marijuana. So we're really in the beginning of piloting lots of work looking at cannabinoids in the treatment of pain as well, in children as well as in adults.
Wow. Let's park that for 1 second, because, again, I want to come back to that. So are you utilizing other elements of traditional enhanced recovery pathways for the kiddos?
Yes. So I would say that multimodal is the way to go, but I think we're trying to do it as responsibly as possible. So one of the real problems in American healthcare is how drug companies basically have been raping the public. And I say that very deliberately. So if you take a drug like acetaminophen, Tylenol, if you use oral Tylenol or rectal Tylenol, it's pennies a dose.
Yeah.
It's as effective as IV acetaminophen, which costs $100 to $200 a dose. Why should anybody be using a $200 drug when a penny drug is just as effective? But that's the focus of how medicine is working. So we're really trying hard to figure out ways to not just use multimodal therapy, but to also use the cheapest and most effective drug of the same class. Yeah.
So and there are a lot of differing opinions about that.
Yes,
for sure.
No, absolutely.
Yeah.
But if you think about it, if you use IV acetaminophen as a very specific drug, it's currently to the patient over $200 a dose.
I know.
Now, for $200, I can go to Costco and get enough acetaminophen for the entire city of Denver.
Right. There's a lot of other things. Yeah, you can get there too for the entire city.
No, but you know what I'm saying.
Yes,
so,
I know.
But nevertheless, the idea. So, acetaminophen, I think, to most pediatric anesthesiologists, is mother's milk.
Yeah.
Like basically
for babies.
For everybody.
Yeah.
So like I think of it as the absolute fundamental building block upon which everything else goes.
Yeah.
Now, is it going to eliminate all pain? Absolutely not.
Yeah.
But say it reduces it by 30%. Yeah. That's a pretty big deal.
It is. Let me ask you, back to the enhanced recovery piece, just we'll cover that and kind of, like I said, move on to the opioids. Have you guys changed the MPO status for your kids or done any other pre-op?
So in pediatrics, it's I would say it's not so much changing the NPO status, but
because that's typically already.
It's pretty well worked out.
Yeah.
But I would say is that there's more of an encouragement to actually drink sugared liquid.
Sugar. Carb drinks
during the period immediately before the NPO period starts. So I think we've always been pretty good at not starving people. But instead of saying, okay, you're going to wait, you have to stop drinking liquids 2 hours beforehand, we're going to say, okay, well, at 2 hours and 30 minutes, we'd like you to have a sugar drink rather than just plain water. So that's part of that pathway. I think the other thing that's a really big deal in pediatrics, maybe even more than in the adults, is the trick to getting out of the hospital or going home is the ability to eat or drink.
Right, and mainstay to enhanced recovery.
Correct.
Post-operatively,
And things that we were absolutely, positively sure about in the past turn out to be incorrect. NG tubes, really not utilizing them. Really avoiding them if possible, as much as possible. Getting people to eat and drink and ambulate as fast as possible. That's part of this ERAS culture. And I'd have to say that I was taught a long time ago by one of my really close friends that if Dr. Collette says that something is true, it's true. So I think we've all become disciples of him. And as I said, my good colleague, Megan Brockle, has been really active in the ERAS Society and getting pediatric pathways done down to the neonate. So this is a lot of changes coming.
Yeah, that's very good. So, are you kind of diving into the opioid thing, because I know that's something you're very passionate about. What are you utilizing more regional tech or regional approaches to care? Or?
So I want to be really clear about this. I think that there's a really important difference that has to be made, and that is it's not so much opioid avoidance. It's really more opioid reduction. I don't think there's ever going to be a time that opioids can be completely eliminated. But I think the biggest issue is going to be is how much is dispensed. So currently, when people get dispensed opioids, they often get dispensed quantities that are much more than people need. And we've done a lot of studies with this. And the problem then is that you have this leftover opioid in the home. And the target audience for drug addiction is actually teenagers from medically dispensed drug that's left in the household. It's sometimes called non-medical use of prescription opioids, NMUPO.
I think the kids are calling them pill parties.
Well, yeah. But the thing is that I would challenge anybody listening right now, anybody listening, any place in the United States, I can't speak outside of the United States, but I would challenge anybody, that's including you and you, to go to your home, open up your medicine cabinet, and I will bet you any amount of money you've got opioids or benzodiazepines or something that you were legitimately prescribed and needed, but nobody ever throws them away.
I'm going to jump in as a non-US citizen living in the UK. So interestingly, we don't, and I think it's that's a clear and obvious cultural distinction I've seen as a very frequent visitor to the States. It's a very American thing to have the drug cabinet with, as you say, benzos and opiates.
And what's really startling about it is if you look in your cabinet, you can say, well, I'm not going to use it. I want to keep it there in case I need it. That's why it's there. I've paid for it. It's mine. I want to leave it there. But what you have to understand is that you may have a person who's a guest in your home who says, "Oh, may I use your bathroom?" Sure. When you're not looking, the door, the cabinet gets looked at. A cleaning person. Yeah. Your teenager.
Yeah.
And teenagers are there. As anybody who has a teenager knows, their brains are wired differently. They consider themselves invulnerable. It's a time of experimentation. And how could this be bad? How can this be bad if a doctor prescribed it and it was dispensed in a regular pharmacy? And then a vicious cycle occurs because despite the really good stuff of opioids, they do have a dark side. And the dark side is that as you use them, you become tolerant and you become dependent.
Mm-hmm. Myron, can I get some context here? Because I don't look after kids in my daily practice. Completely get the kind of bystander opioid risk. The data we hear from adults suggests maybe 5 or 10% of adults undergoing major surgery are becoming opioid dependent. What sort of how does the picture look across the spectrum of age in children?
So the first thing is we don't know. We absolutely have no data. There's zero data. But the very little bit that exists says that it's very small. It's a very, very small percentage. It's probably in the order of 0.05%, less than 1%.
Interesting.
However, it's not really good data. So it's not something that I would want to hang my hat on. But at this moment in time, of the limited amount of data that we have, it doesn't seem to be that much of an issue. The other sort of thing about this, the medicine that's left in the cabinet. So even say I was a good parent, a good citizen,
We're
a good patient.
You are.
Yes. Well, I'm not sure my kid. No, I think my kids are big, but they're older. They're your age. But if you want to get rid of the medicine, until last year there was no way to do it.
Yeah.
Because the Environmental Protection Agency says that under no circumstances should these things be flushed into the toilet. The Drug Enforcement Administration, same government, just across the street from each other, says, the only way to dispose of it is in the toilet. So you got two different agencies telling you two different things. And then the consensus was, bring the stuff to a pharmacy. Well, what's the pharmacy going to do with it?
Yeah.
They don't know. Bring it to a police station. What are they going to do? Nobody knows what to do with this stuff. So that's a real problem. For the listeners, I will tell them one quick tip. there is an easy way to destroy of these medicines. If you have the desire, and I think people should, there is a simple, very simple, environmentally easy way to do this. If you take any container and put either soap detergent or laundry detergent and make a solution, shake it up, and put the medicine in it, it completely dissolves it and makes it inert and unpalatable. So it's a very easy, and then it can, excuse me, even the EP says it's okay.
Really? Did you know that?
I did not know that.
So that's a very, very simple way to do it. Now, there are other ways too, but they're a little bit more complicated.
Top Med Talk. I mentioned at the start our back catalogue of over 300 podcasts. You can download all of these completely free today. Top Med Talk is committed to open source publishing and will remain so for all new material. As we continue to grow beyond our expectations in subscribers and engagement of thought leaders around the world, we will be diligently working to enhance the experience of our listeners by creating a back catalogue, a highly curated collection of our podcasts, advanced search options and special bonus features. This will be available through our new app at a fee. So we encourage you to download all of the podcasts right now. It's completely free through to the end of this month and contains some absolute classics from some of the greats. Enjoy.